Welcome to the Finance and Facilities Committee meeting. Today is Monday, December 9th, 2024 for the School District of Waukesha. Can we verify that the meeting has been properly posted?
Yes, it is.
Okay. The next item of general business is an opportunity for public comment. Do we have anyone who signed up?
Nope, no one signed up tonight.
Okay. Moving into our action items, the first action item tonight is the approval of minutes. Be looking for a motion.
I move to approve the minutes for our meeting in November.
Second.
Second, been moved and seconded. All those in favor say aye.
Aye.
All those opposed say no. All right, passes 5-0. The next action item for this evening is the approval of vouchers. Did we receive any questions this month?
There were no questions this month.
Okay. So I would be looking for a motion to approve.
So moved.
Second.
Okay, moved and seconded. All those in favor say aye.
Aye.
All opposed say no. It passes 5-0. Moving on now to our discussion and information items. The first item tonight is the athletic cooperative reports.
Yeah, we were talking a few weeks back, Jim and I were having a conversation. We thought maybe it'd be good to bring in the athletic directors, and we have Eric and Dan here from North and South. Kyle couldn't be here tonight. Just to kind of go over all of our cooperatives, because oftentimes we talk about them kind of as one-off, standalone conversations. And there's a little more complexity to the approval process and all that, so I thought it would be good to just have them come in and do just a little informational presentation, and then we can answer any questions you might have. So I'll project and then turn it over to Dan and Eric to walk us through it.
All right, good evening. As Darren shared, I'm Eric Plitzwhite, Athletic Director at Waukesha North. Our agenda tonight that we're going to go over the cooperative creation, the approval process, the current cooperatives that the School District of Waukesha is currently in, and then our participation levels and what that looks like. So the approval process that we go through, the first thing is that we look at, is it going to be a value add for the school district? We want to make sure that obviously that our programming gives our students an opportunity. Does it assist neighboring schools? Does it fit into other activities, facility use schedule? And we coordinate the agreements between the other school district Waukesha high schools. And does the partnership then take away, because when you add, you might potentially take away from the school district of Waukesha students too by adding co-ops from other school districts. One thing to note, the current co-op agreements that we have with the district and with other districts, they seem to be long-standing, unlike me being brand new here this year, so.
And when we say, does the partnership take away from SCW students, we're mainly looking at like opportunities, athletic opportunities. A lot of the goals of the co-ops are to provide more opportunities. Teams that might not be able to stand alone at one school, we create a co-op so that there are more opportunities for kids, more opportunities at appropriate levels for kids to play.
So the process itself, and the WIA speaks to this, and I'm not going to go ahead and read all of this, but there's numerous things that we have to make sure as a school that we have the approval on. Obviously, we have to have the approval of the schools that are involved. That's the biggest thing. And then we need the approval from the school board, the governing bodies of the school districts that are part of the co-op. The approval of the conference in which the cooperative team will exist. The conference does need to approve that. I've seen it on both sides where conferences have approved and they've not approved. When the conference chooses not to approve, obviously it stops there. Then the program itself must adhere to a no-cut policy. I think a fine example of this is our girls basketball co-op that we currently have, Waukesha North and Waukesha South. It's a no-cut policy. This year we were able to have 3 levels of girls basketball, which is a win for us as a school district.
The ultimate goal being to build the programs, to give opportunities for students so that more students are interested and able to play that particular sport.
And then with the WI too, with that process, there are deadlines that we have to follow. The WI is pretty strict on. Fall sports is October 1st, February 1st for our winter sports, and then May 1st for our spring sports.
And point four might be interesting as well. In terms of enrollment for divisions, you might fall as a Division I school for some sports, Division II school for some sports, Division III school. When it comes to a co-op, they use the combined enrollment of all the schools in the co-op for division placement. So the next slide just simply states that, for the most part, co-ops that STW is involved in or are involved in live inside of the district. The only one that we co-op out is girls hockey. Girls hockey is a co-op of about 15 schools. It's an incredibly large co-op in that there are a number of schools involved. We might have 1 or 2 students from South on any given year who play on the girls hockey program. That provides them an opportunity to participate in girls hockey.
And that's housed at the Elmbrook School District.
So then the next few slides, the first one details the co-op billing process. That's billing outside of the district. If the co-op exists only of School District of Waukesha schools, we work together during the budgeting process. We don't bill each individual school. That said, if we have a school outside of the district that belongs in one of our co-ops, there is a billing process. For example, for boys swim, Waukesha South co-ops with CMH, we create essentially a bill for CMH that includes many of the things listed. There might be other things that come up from a year-to-year basis, but entry fees, those are fees that we pay if we go to a tournament in Beloit Memorial. We might have a $200 fee to compete there. We include that. We include the coaches' pay. Those are head coaches and assistant pay. If we host events and we have officials, we include that as well. Event workers as well, so timers for swim meets or officials. If there are any facility use fees, new equipment purchases, if that's applicable, and then transportation. So if there's busing, that's also included in the co-op billing. What we do is we do a proportion of athletes. So say there are 20 athletes on the South CMH swim team, and 5 of them are CMH. We create a total bill, and that would be a quarter of the total cost because it's a quarter of the athletes on the team. So the next few slides then detail the current co-op opportunities housed in the School District of Waukesha. This first slide are all the swim teams. So you'll notice that South, West, and North all house co-ops for both boys and girls swim teams. You'll also notice that those aren't consistent. For example, CMH co-ops with South for the boys, but they co-op with West for the girls. These are long-standing co-ops that have been around since before my time in the School District of Waukesha. Some of them have slight changes. For example, Oconomowoc was added to the Waukesha North Boys Co-op this year. We'll look at some of those numbers in a little bit. Most co-ops, and I say most because gymnastics and I believe lacrosse are on a 1-year renewal basis. Most co-ops through the WI are on a 2-year renewal basis. So the approval process isn't as, I would say, intense, but they do need to be approved by the conference again, our school board president, the ADs, and our superintendent. And that's where the expiration column on the far right lies. That's why it's every 24, 25, 25, 26. Every 2 years, we're looking to renew those co-ops if that's something that we feel like would provide the right opportunity for our student athletes. These are all of our non-swim co-ops then. So again, girls golf at the very top, that's Southwest and North. I believe that's been a co-op since the early 2000s. Boys golf, for example, is not a co-op. All 3 schools have standalone programs. Boys volleyball was co-op between South and North the year before I stepped into the athletic director role. Girls basketball, we're on our 2nd year of the co-op there. Gymnastics is one that's renewed every year. That used to be a 4-team co-op, West, South, North, and CMH. Due to some changes in the WIA regarding postseason participation, we split into 2 separate co-ops. Boys and girls lacrosse, both are housed at West. They are now a WIA sport officially this year. So that renewal process is a yearly process. Boys hockey is co-opted at North. That has changed. That was at South for a while, but it's now at North. Ski racing and snowboarding are not officially WIA sports. Those are housed at West High School, but include students from all 3 schools. We also have Heritage Christian as part of our alpine ski racing. They don't follow the same WIA requirements for co-ops, so that's why that expiration date says not applicable. And then diving really is a co-op based on that we have one coach, but those diving athletes follow our swim co-ops. The next slide will take us to a link that details all the participation levels. It also details the billing that we provide schools that are not in our district. So that's the line item that is highlighted in green. So you'll notice traditionally, there's a lot of data to look here. These are all of our co-ops the last 5 years. You'll notice that traditionally the numbers are lower than other sports in terms of the number of athletes at each particular school. Again, the goal is to be able to provide an opportunity for as many athletes as possible to compete at appropriate levels at their sport. You'll also notice that the line item for the last amount bill might look a little different from sport to sport. For example, the last amount billed for girls swim at Waukesha West was $1,980. That's that top left green number. That's pretty different than the last amount billed for the girls swim at Waukesha South, which is $5,013. A big piece of that is the amount that we host at Waukesha South in terms of swim, but it's also the participation numbers. So again, if you look at the top left column, CMH had 5 swimmers for Waukesha West girls swim. Mugwanago has 10 swimmers for South Mugwanago swim, so they have just a higher portion of swimmers, which means that billing is a higher portion of the total amount.
Any questions on, I know it's a lot of numbers to throw at you on one slide, but, or in one spreadsheet.
I have a couple. Thanks for all that. Just a clarification. Am I on? Yeah. Is that only during the season that we're billing, or is there
Correct.
during the active season?
It is only during the active season.
Okay, so that amount billed is essentially, well, is that when does that happen? Is that a season amount? Is that a quarter amount, month amount?
That is a season amount.
Okay.
In schools, we've learned that schools work with that amount in different ways. For example, there's a school in one of our co-ops who then bills their athletes. There are also schools that fund it through their district funding process, and it's paid like any other sport would be paid at their school. So,
No, that makes sense. I've actually received some fundraiser requests from some athletes at other districts or other schools. So I was just curious about the amount itself. I forgot my other question. It'll come to me later, though. Thank you.
I got a couple.
I got a couple of questions. I think you sort of answered the long-standing, sounds like that's several years or maybe decades of what a long-standing relationship or co-op agreement was.
yeah, for the most part, when we look at girls golf, the swim co-ops, those are co-ops that have probably been around for over 15 years, 20 years. To be honest, I'm not even sure when some of our girls and boys swim co-ops started. I believe the girls golf one was 2001. It's just a different process when you renew them. You renew them every 2 years, but there aren't as many questions that you have to answer about, like, why are you doing the co-op? Because we continually provide data as to like where our numbers are and what opportunities we're looking to provide for students. Now, if all of a sudden we had a program absolutely take off and we have 40 students from South in our girls golf program, that might create different questions about, is it time to split a co-op, or is it time to create a co-op based on participation numbers? Those are questions that we reflect on, but it's just a little different process when you're renewing based on if you're creating one.
Okay. And then you had mentioned, I think Eric did, sometimes they're not approved What would be some of the reasons not getting approved?
From my experiences, there's been school districts that I've known that have not approved based on vouchers being brought into the school district, and so sometimes, a public school might not want to take a private school in for that reason because they're taking their students and taking opportunities away. But that, again, that's not from my time here, that's from my previous
Gotcha.
work experience.
I've seen co-ops denied at the conference level because it creates teams that are bigger than other conference teams. So we might see it as an opportunity to have more student athletes at appropriate levels, JV2, JV, varsity levels, whereas there are teams in the conference that might not have those same opportunities, so they simply deny at the conference level.
Gotcha. And then lastly, the 2-year renewals, I can surmise some of the reasons for that, but why is it 2 years?
I think the WIA is looking to make sure that if our programs are flourishing, that we are then getting back to standalone programs. And so it's a 2-year cycle that the WIA has in place for everybody. So, like our basketball one, we'll reevaluate that in the next, month here and figure out what that looks like, and just like we would for all of our co-ops.
The goal would be to have, girls' basketball, for example, would be to have 3 healthy levels at both schools. Same with boys' volleyball. Ideally, we have 50 kids who want to play boys' volleyball at both schools, and we're able to provide freshman, JV, and varsity levels, building up those programs from, where we were maybe 3 years ago to where we want to be in 5 years. And then you just reevaluate every 2 years. That's not always the ideal world that we live in. So we have to just continue to reevaluate where we're at and what opportunities we can provide students.
Good. I'll give you enough time to remember your other question.
I can't remember that question still, but I had a follow-up question.
Yeah, go ahead.
To what you had asked, which is about the 2-year. I mean, what I've seen is we have more co-ops coming because participation is a challenge, right? And it's great that we have this option. If I understand it correctly, though, it is possible to reverse a co-op after a year. You're just only approved for 2 years. Is that correct? I know we've never really had that scenario, but is it the approval for 2 years, but you could go back?
Yeah, I've never approached that in my 16 years with co-ops.
Okay.
I've never had that. I would imagine it's got to be an option.
We're just seeing so many more of them. I wonder, sometimes you do the co-op because we're struggling to create a program. And then, to Dan's point, maybe the program takes off. Basketball is one, right? Where what if, you had 50 girls who wanted to play one season, and then
Yeah.
your 2-year co-op agreement, can you separate that?
Yeah, if you go back, to slide 4, I believe, it does say that the agreement must specify 2 years, but the agreement may be terminated by the Board of Control for documented extenuating circumstances. So if we were able to have standalones.
Also, I think it is important to note that the co-op agreement is at the varsity level. So there have been conversations, girls' basketball, that you're agreeing to co-op at the varsity level, which if for some reason you do have 2 healthy programs at the JV level and you want to split there, you can start with a split there and then co-op at the varsity level or look to split at the varsity level.
And boys hockey is a prime example of that right now as well, where it wasn't approved at the conference level, but we have kids that are from other schools that are on our JV team. So I know that's another real example for the school district of Waukesha.
Thank you. I'm curious about, I know you said they're longstanding and predate both of you, but I'm hoping perhaps there's some context that someone might be able to provide that just comes from institutional knowledge. It seems odd to me. Well, let me back up. Maybe there's an assumption I'm making here that isn't true. My assumption is Waukesha South, Waukesha West, and Waukesha North could not stand on their own as individual varsity programs in swim, boys and girls. Is that a true statement? Like we couldn't have each school with their own swim team without a without a co-op. Is that fair?
I think that's a challenging question. I think part of that, especially with the individual sports, I come from a tennis background. I coached tennis for over a decade. A lot of the individual sports, you can survive standalone because you're entering meets, you can enter meets as an individual.
Sure.
Golf, for example, you could have a two-person team and you could enter as a two-person team. I think of some of the tennis teams that have existed in the past where you certainly can have a six-person tennis team. But if you look at the opportunities that provides student athletes, having to play the varsity level with six players, maybe not matching up perfectly with another conference team, I think it does hinder the growth of the sport and the team. So I think it's a challenging question, and yes, you likely could have a team, depending on how we define team and opportunities and what we're looking for out of those opportunities.
So maybe the better way to phrase it is, co-ops provide the best opportunities for the athletes at South, West, and North participating in swim for both individual and team competition. Is that maybe a better way to phrase it?
Yes,
I would agree with that.
absolutely.
So, given that, I find it interesting that instead of co-oping within the district, South, North, and West, forming one team like we do in boys volleyball or we do in girls golf, that we have instead created 3 separate co-ops with districts outside of our own. Do we know what the reasoning is for that? Is there some reason why that is more of a benefit to our schools, to do it that way than to kind of keep it in-house, for lack of a better term, and make more efficient use of the resources we have?
I mean, I think it's a interesting question. We do have pools in the school district of Waukesha. Not every high school has a pool. So I'm sure that's part of the conversation that was started, 20 years ago. I don't know all of the reasons why, to be honest, why they were created. I do know that one thing that successful co-ops do is they create a team-like atmosphere where everybody from the team, you couldn't tell if they're from CMH, South, North, KM, and really strong co-ops have created like a family feel regardless of what school they're at, and a very long-standing family feel. So do I know exactly what those conversations were 15, 20 years ago? I don't. But I'm sure the fact that South, North, and West have pools played into some of those decisions.
So if I could just follow up on that. Here's my concern. So I get the fact that some of these schools may not have pools and they're seeking partners so that they have opportunities for their students to participate in these sports. But I recall when there was some sort of initial discussion around the future of the pool at North, we actually had parents from outside of this district basically telling us we must keep the North Pool in order to provide their kids with the opportunity to continue to swim. I'm all for trying to help out districts around us, but not at the expense of doing something that doesn't make sense for our district. And so this is something I'd like to see perhaps looked at more closely. Do these swim co-ops still make sense, given the financial situation that districts face, including our own, the decline in participation? And I think what really should be the goal whenever possible is when our schools need to co-op in order to provide opportunities, that we seek first to co-op within the district. So let's leave it at that.
Mr. Zenobia?
Yeah, just, you had mentioned early in the presentation about denying co-ops. I was just curious if that does come up, maybe with smaller schools or what have you. Kind of curious if there's demand for our facilities that we have to deny some of these, or is that just Do you have any experience with hearing about any of that, or is that not something that happens often?
Currently, I've got two schools that are looking to add to our co-op for hockey. And so, and it's because they don't have facilities, but we're not housed in the school district of Waukesha for that. I mean, I run the co-op, but we play at Nagawaki. And that has been denied in the past for adding teams at the conference level. Maybe not at the district level. And again, I can't speak to that. So I do have schools that have reached out about, becoming more a part of it. I don't know if that answered your question or.
I don't think I've seen that outside of hockey. Hockey, maybe lacrosse, but we don't get approached very often about creating new co-ops.
Okay.
One-off schools might ask to be part of one of the bigger hockey co-ops, maybe lacrosse, but I don't even know if I've seen that. I feel like that's a conversation with some of the multi-school hockey co-ops or bigger co-ops.
Okay. Thank you.
Dr. Piasek?
You said hockey, so I have a couple hockey questions. Not to mention, hockey is very expensive and it's extremely dangerous. So when we host a co-op, what liability do we have around the financials around that co-op and the health and well-being of the athletes? And that's probably, I don't know, think it's a question for you guys, maybe it's a question for administration, but I work with a hockey mom who tells me these nightmare stories about what her kids are going through, so I'm just curious, and because nobody has facilities for hockey, right? You're just trying to put a team together, so we're practicing out, we're playing out, we're traveling a lot. What does that look like from a liability perspective?
Sorry. Maybe I can follow up with our insurance consultant and send it out on the Friday update. I just don't know the answer off the top of my head.
Okay. And then, if I understand correctly, Wings Hockey is maybe the only co-op that has its own standalone board. Is that correct?
Yeah,
We
they're
have
a
other
unique
co-ops that
arrangement.
have their own board. So it's
There's
an
a-
expensive sport, so I understand there's other dues and things that come along with that because you have to rent ice time and all that stuff. What liability do we have financially to ensure that the dollars that are associated with that program are being managed appropriately? If they're not coming to us, we're not billing directly. I'm just curious, what's our liability for that?
I don't know what our liability would be in that situation. It's a different, they're their own 501c3 organization, so it's completely different than any of our other co-ops. I'm just not sure what our exposure would be to that.
I think the unusualness of it is what probably leads me to all of my questions, right? Because we don't have other things that look like that.
No.
And so I just think about all kinds of things, and this isn't, I can't tell you, I don't know who's on the board or anything like that, but we vet coaches, we hire coaches, we oversee those contracts, we pay invoices for other facilities and things, golf courses and whatnot. But I don't know how much of this stuff we see, and I don't know how much we're responsible for. So I think we should maybe understand that well, and
Yeah, if you recall, Sherry Stack, when she was still working with us, did a deep dive into that, and I'd want to go back and see what I don't know if we reported out at a meeting or if it was a Friday update or what that was, but I'd want to go back and reference her work on that because I want to say it was like 3 years ago. You were here already, so it wasn't that. And we could bring that back too as a Friday update but it's a different, definitely a different arrangement, but hockey's a different sport in a lot of ways too.
I mean, it's such a great example of what you can do with co-ops, and when we've got schools across the county that can come together and kids can play together, and I know, the girls are associated out of Brookfield, but it's great that they can play a high school sport and get all the recognition from the WIA associated with that. Again, because it's so big, I just hope there's a lot of clarity with the various districts that are part of the co-op that we know, we all agree on who's responsible for what.
I'd say this was a good presentation. I appreciate it. This is always one of those anomalies that has so many different prongs to it that we get a lot of questions, and I would say probably don't necessarily understand how the individual co-ops move and freeze. But I do want to highlight, a couple of the pieces that we hear. So with the agreements that are renewed every 2 years, I think the ask that I'm hearing is just to understand this isn't an auto-renew button. And at a point in time where I applaud and love the fact that we can merge within our district to get our students to be able to participate, I think it does raise the question as to a couple of them where the support becomes building and leading up to districts that are not our own. And how do we navigate that? And are we asking those questions when we're renewing them? And they are hard questions, but I think they need to be asked versus this has been in place for 20 years. And because it's just been in place for 20 years, we're just going to keep it going. I don't think those are the right questions anymore, or the thoughts, especially as we are facing a different viewpoint on a financial landscape. But promoting the ability for our students to have access to be able to participate, I think is extremely important for their growth and all of the pieces in their high school learning. So I'll leave it at that, but this was good.
All right.
All right, our next discussion item is our health insurance report.
Yeah, tonight we have our representatives from ProHealth and the employee clinic, and then the next phase of it is Jeff Schultz is here, our consultant, to talk about our larger health plan and RX coverage as well. But I thought we'd start with ProHealth. They come normally around the end of the calendar year. And Kristen Morose, who's our benefits coordinator here in the district, I've asked her to come too, just in case you have any employee view questions or something that we can respond to. So I'll turn it over to Vicki and I'll let you introduce yourselves, and then we're here to answer any questions you might have. And then we'll bring Jeff up after ProHealth goes, so.
Great. You all know Kristen. I'm Vicki Dahlman-Knappe, Vice President of the area. I've been to this board several times. Nice to see everyone again. We have Laura Anderson, who's the dedicated manager of the clinic, as well as Mark Leno, who is our pharmacist that is managing all of our pharmacy and the kiosk that we presented last year at this time. So I'll move forward. Pete couldn't be with us tonight, and that's just kind of our regular screenshot that we have when we were very young. Some of the meeting goals that we wanted to reiterate was accessibility, quality care and patient experience, utilization of technology, and affordability. That was the original vision of the School District of Waukesha and part of the request for proposal. And we want to continue with that vision until we're told not to or change. So many of our slides tonight will focus on just these four sticking points that we really are trying to bring forth to the district. We'll go to the next slide. Just to reiterate the clinical program, it is a near-site program. We have a location at Brookfield and in Waukesha at the Sunset location. In-person and virtual options are available both for primary care, episodic, and urgent. We also manage the employees and the occupational health, so onboarding a new employee for pre-placement or if an employee is injured, as well as wellness programming. This fall, we just completed our wellness programs with the district that encompassed a health risk appraisal and our flu shots. We'll go to the next slide. Just so you have a photo, the School District of Waukesha chose the two newest clinics that we just built. So Brookfield was our first location, and we also had Waukesha Memorial. But when we built Waukesha at Sunset Drive, which was so much more convenient for the school district, they could drive right up at Brookfield as well. They just love that site. Laura's going to show some statistics in a few minutes, but most of the book of business goes to the Sunset location. Your new hires, like Brookfield, because they're newly getting hired, they could be all over the district, and that seems to be a convenient site for new employees. We'll go to the next slide. Our hours of operation currently under our agreement are 40 hours. And you'll notice that the 3 bullet points are more than 40 hours. So how we manage to keep track of how many hours you all use is just by the visits that your participants are seeing. This doesn't include the time that the provider or administrative team is working on those patients for the day. So you'll see our Sunset location. We quickly realized with the help of Darren that maybe our 8 to 4:30 wasn't enough, so we extended hours for the evenings for working teachers and working families so they could come to appointments in the later afternoon, early evening, as well as children, so pediatric care has grown. Our Brookfield location is open 8 to 4:30, Monday through Friday. Again, most of the folks going to that site, they can use that site for primary care, but they mostly use it for occupational care. Our virtual and e-visits are extremely popular. Laura's going to get at that in a minute, but we're open from 8 to midnight every single day, 7 days a week, excluding holidays. So that's been a wonderful opportunity for your folks to have a quick visit, maybe in between classes, before work, or when they get home, all day Saturday and Sunday again till midnight. We'll go to the next slide. I'm going to turn it over to Laura, who's going to go through our statistics.
So our primary care statistics, these include your video visits, the e-visits, acute care, adult preventative, well child, chronic appointments, lab, and nurse visits. So the data here shows from January to November 2024. There's been a total visit count of 758 primary care visits. As you can see, the vast majority of the participants are utilizing the clinic for their acute needs. If you combine the video visits, acute visits, and e-visits, there were 617 out of your primary care. So we offer both employee health and OC health appointments at the Brookfield and Sunset location. Total, there have been 415 combined visits for January through November. These visits include your pre-placement exams, work comp, and work comp follow-ups. So for 2024, there's 351 pre-placement exams, 26 work comp visits, and 38 work comp follow-ups. Just to kind of say what Vicki was saying earlier, most of your acute care is going to Sunset. A lot of the pre-placement exams are being seen at Brookfield, and it's a good, 80-20 split right now with visits. So combined visit totals, so this is going to include both your primary care visits, employee health, and occupational health visits since January through November. The data reflects a total visit count of 1,173 visits. Again, the majority of these are going to consist of acute visits and pre-placement exams. The next slide will show you the year-over-year progress and continued growth of the clinic utilization.
We also wanted to highlight here that currently we're at 62% of utilization of the slot appointments available. We're almost reaching that capacity where we really have been speaking together as a group. We meet with your HR department and Darren every month to look at in 2025 some increase in hours, and we will bring that proposal to the school district, but just wanted you to know we're almost there. We're currently at 40 hours per week. We're at the tipping point where we have to increase hours. So that being said, we would increase probably by 20 hours next year in 2025. So a total of 60 hours would be available, both at the Brookfield and Sunset location, as well as obviously the e-visits and virtual visits. So we're getting close. So that's a good thing. So folks are using the clinic like we expected, and we appreciate the ramp up that we've seen since we opened in 2022.
Health risk assessment. So looking at the recap of this year's HRA program, we made a few changes that we feel that were very successful and received very positive feedback. So we offer appointments mid-October through mid-November. There were 1,600 appointments available over the 14 scheduled days. And we hosted at 13 different locations this year. New this year, we opened the Sunset Clinic on 2 Saturday mornings in lieu of West High School. We received a lot of positive feedback, allowing for additional privacy, hosting it at the clinic, accessibility to the clinic, they're able to park and just walk in, ease of appointment and check-in, and location. I know Kristen and I have talked to, I know she's received a lot of positive feedback from the participants to hosting it at the Sunset location. So when we prepare for next year's HRA, we're going to look at maybe adding on some more Saturdays for the HRA. The next slide. Oh, there it goes. Perfect. All right, so the HRA and flu programming for this year, the data is reflected, like I said, from this year's fall HRA program. We completed a total of 1,435 HRA appointments, and 853 flu vaccines were given. We remained pretty consistent over the years with the HRA participation. And I know that Kristen and I are just finalizing the data too. So patient experience. So we survey our patients on the services they received through an open platform. They do receive a text message to their phone, and they're able to respond to a few questions, ranking each experience 0 out of 5. So they are asked, how satisfied are you with your scheduling experience? How satisfied are you with your appointment date and time? And how was your overall experience? Our goal has always been to provide high quality care. The data shows a high rating of 4.75 to 4.9 ranked between the 3 questions. And this data does come from the 2 clinic locations. So what are patients saying? So I was able to pull some feedback both from our provider and from a patient. So I'll quickly read through this. So our first one is from Jackie Radai. She's our nurse practitioner out at the Sunset location. She said, I had a patient yesterday that said the kiosk was amazing. She had been prescribed albuterol by another provider and sent to her local pharmacy. She was not able to fill it because it was not covered by the insurance and required a different brand. She came here and it was able to fill quickly with no holdups with insurance and only had to pay $2. The next is, I had a patient recently that was actually switched to my schedule from the urgent care with the patient permission when they realized she had Waukesha School District insurance. She was very happy at the speed at which she was seen and that she was able to walk out with her medications rather than making another stop at the pharmacy. And that was from Rachel Gunther, one of our other nurse practitioners out at Sunset. And lastly, this is from a patient. I was seen last night at Sunset Clinic, and it was incredible. Was able to get all of my medications for $6, which saved me a Walgreens visit and a lot of time and money. Really appreciate the medication dispensary at the clinic site. Your staff was wonderful, and the whole experience was extremely efficient. Thank you for this service. It saved our family. Yeah.
Okay. This is our quality. One of the really deliverables we talked about is making sure we were committed to quality around preventive health measures. And we have a color coding here. Obviously, blue or green is stellar. Red means opportunities for improvement. So we have a really strong performance in the majority of our metrics. These are well child visits that we're doing, statin therapy for folks with cardiovascular disease. You can see we have an opportunity. All the cancer screenings are at stretch performance. Our influenza hasn't caught up yet. This data was just pulled in November, so we haven't completed our all the vaccines being loaded into the quality software. Our breast cancer screening, our diabetes control, and hypertension control are stellar. So just wanted to point out that we are providing affordable service, easy access, but quality as well. You all are signed up with UHC. We also see these numbers when we're looking at UHC across the continuum. So we continue with that with the School District of Waukesha, paying very specific attention to your population and pulling that out and working. And again, we have one opportunity here is to really start to work with your folks on statin therapy. So those are folks that have had elevated lipids on maybe their blood tests. And a kiosk opportunity would be available for us to dispense medications at the Sunset location. So wanted to bring you that today to show that we are really addressing quality, and you can tell that our performance there is outstanding.
So affordability, so the current agreement, so the participant pays $30 if the deductible is not met. And this includes for their office visit, their virtual visit, simple labs, simple radiology, and the claim is sent to the UHC for tracking. Once their deductible is met, they pay $0 copay. We still send the claim to UHC for processing and tracking though. For the OC Health and Employee Health and Wellness Program, that is a bundled pricing that we offer. Anything else? Sharon?
No?
Okay.
All right, so now we get to talk about the kiosk. How many of you folks in this room have experienced our kiosk so far? One. All right, so,
The rest of us
Our
are,
board members.
oh,
Yeah.
my mistake. Yeah, a couple of reminders, high level, right? Our kiosk, the way that we kind of developed this program out was really looking at those adherence medications in a way to help to drive down overall insurance costs and ultimately help to improve patient outcomes by having a convenient way and an inexpensive way to have their medications filled out of pocket. Affordability has been fantastic. The patients that I've interacted with that have utilized this program so far have been very, very, very happy that in theory, they can pay $2 and get a 3-month supply, sometimes a 6-month supply, or a year's worth of birth control. This has been a fantastic benefit that I've heard over and over and over. In addition, when we get to, well, actually, why don't we bounce to the next slide? Whoever's got the, when we look at kind of our fill data. Earlier in the presentation, Laura was talking about how a lot of the visits that we've been seeing in the clinic have been acute care related. And what we've been seeing from the pharmacy aspect, we're also seeing a lot of those acute care type prescriptions, the antibiotics, the cough suppressants, I'm here today because I'm just not feeling well. We are still looking to see if we can increase that amount of those long-term maintenance medications to truly get that return on investment of the machine inside of this location for your participants. Our goal is to get about 300 dispenses out of the machine a month. And as you can see, we had a high point in April, but we've had a various level of utilization of that machine. Again, that really kind of ties back to that acute care aspect where people aren't we're still working on trying to get that word out to all of the employees to utilize this for their maintenance type medications. That being said, we have dispensed 301 prescriptions from year to date. We've had 149 unique patients that have come through. 60 over-the-counter medications and 241 overall prescribed medications. For those that have utilized it, again, I've heard a lot of good things that have come back, especially in the fact that it's a one-stop shop. I came in, I got seen, I was able to leave without making another trip to another location, and it was relatively inexpensive. On top of that, there is a wait time at most pharmacies when you go to it. Sometimes it's on the good side 15 minutes, and sometimes on the bad side a little bit longer. That being said, looking at our dispense data over the course of time since we've had this machine in, including the fact that this is brand new for us as well in learning all of the kinks, our average dispense time is anywhere between 15 and 20 minutes. There have been some instances that we've learned very well about that has allowed us to make that as efficient as possible. So moving on to the next slide. Overall, if, just to kind of walk through the process, patient enters, gets seen, identifies, or the provider identifies that this patient is going to need a prescription. That prescription is generated and sent over to our pharmacy team, who then reviews it and looks for clinical appropriateness, make sure weight checks are okay, make sure there's no allergy reactions. They go ahead and authorize that prescription to go back to the machine, and then the on-site clinic team that just saw the patient is able to ultimately dispense that out of the kiosk, hand that over to the patient, collect a signature for receiving that, and collect payment all in that one transaction. And then we go to the next slide.
Communication and promotion. So we continue to meet with the administrative staff on a monthly basis. We meet with Kristen and Darren monthly to review clinic stats and upcoming promotional events. We've prepared content for participants and prepared flyers for informational use. So I know when we have new pre-placement exams, if they're getting on the insurance, we do have packets made up so that they're getting the information right away at their appointment. We've continued to utilize the fall HRA program as a touch base with the participants. You know, hosting the event at the Sunset Clinic this year allowed individuals to visit the clinic that have not been there yet. So it was a nice way to introduce them to the clinic, and you know, they're able to see where it's at, how easy it is to park, walk in, check in, and utilize the clinic space there. Cost savings. So Acrisure was able to pull cost savings data for tonight. And some of this we had previous. So 2021 to 2022, there was a cost savings of $315,626. 2022 to 2023, a savings of $574,079. And then 2023 to 2024, they were able to give us a savings of $584,088. So that leads to questions or discussions that you have for us, our team.
I will start. I just have two. I want to step back to the process where the kiosks are being used for the acute care, but not expanding to the routine care. And so there are a couple questions that I have on what that process would hopefully look like. So if I have a blood pressure medication that I get, and depending on the insurance, it's 30 days or 90 days, however that is refilled. How does that work?
Fantastic question. If you've been seeing a provider external to the occupational health team, all that would need to be done is a visit with one of our providers in the occupational health team to review your prescription, your blood pressure medication, identify that they're going to prescribe it, and then send it to the kiosk. It's just that singularity of an appointment, and we're able to move that forward.
That's interesting because it takes away the step from the PCP. And the reason that I'm asking this is because, and here's my finance brain and how healthcare is using revenue streams. So if I have to go in for an annual med check just so I can get my prescription refilled, can this be done through the occupational team as well?
Absolutely, we want it done through us.
And it's cheaper for,
Yes, both the participant, so remember, if they've met their deductible and it's chronic, it's not prevention, right? Prevention's
Right.
covered at 100%, so put that over here. But I have a blood pressure or a thyroid issue, or I have diabetes. I know that I'm on a high deductible plan, I'll pay for that whole visit if I see my independent chosen provider. If you come to the clinic and see the clinic providers, it's $30, or it could be $0 if you've met your deductible. If you're getting Lipitor or metformin or losartan, it's $2. And you get it there, and you can get anywhere from 30 days If it's a stable med, we can give you 6 months, we can give you a year. But if we're adjusting your meds, maybe your blood pressure isn't where it should be, we say, let's give you 30, come back and see the nurse in about 2 weeks, we'll redo your blood pressure, make sure you're doing okay on that medication, and then we'll give you the drug for a little longer. But we want to move the folks that have chronic illness into the clinic so that we can care for them. We don't negate the primary care provider relationship at all, and we don't say that we want to replace that at all, but this is an opportunity that we can. We really don't want duplication. So they are able to handle both acute illness as well as chronic illness.
No, I like that. I'm just wondering how we market or push that out. In the where I wanted, the next question, so it was Kristen, right,
Yeah.
where that goes, but I want to lead that into,
You had to have a
No,
question.
well, and we've communicated that, and I think part of it is a cultural thing. People they don't want to change, they want to stay with their doctor, and I don't even understand if they're fully grasping it, because they're like, but I have to see my doctor to then see the clinic doctor, but I don't want to change from this person because I've seen them for 10 years. I'm like, you don't have to, you can still keep them as a primary care doctor, but then you can follow up and pay $30 and get your prescriptions for less. And I just think part of it is a disconnect, that it's not clicking, they're thinking they have to see two different doctors to be able to get it.
so that, and this is the perfect piece to that, because there's two pieces. So when it comes into the cost savings, so the last slide that we looked at was the cost savings per the district. My brain wants to understand how the cost savings are calculated, but in theory, by going to this process, not only is it saving the employee, but it also has a significant benefit to saving the
That's
district.
correct. The more people we have, obviously, the more savings there are. And when we came last year, we really talked about that 300 dispense. That gets to about 10 to 15% of your pharmacy costs at a really reduced amount, a contracted amount through ProHealth. Even with only $2 coming out of the employee's pocket, there's still a significant saving for the employee and to the district, because we're working on a kind of a direct-to-employer agreement between ProHealth Pharmacy and the school district.
So this is a no-brainer for me. And then just one follow-up question,
Yeah.
Kristen, for you. Do we do anything to incentivize our staff?
Darren and I have actually had that discussion to drive more
Right.
to the clinic. We worked with ProHealth on getting this kiosk. We are the first district, first employer to use a kiosk at ProHealth Care. And working through like what it all looks like and how to drive people there to utilize it, because it does save them money, $2. And it saves the district, because we are paying less because of the direct supply connection to the district. We do think, after speaking with Acrisure too, on our last end-of-year meeting, we changed our prescription coverage to cover 90-day at a pharmacy location, not just by mail. So that percentage of people that are utilizing the extended day supply has drastically increased. So because that increased to 90-day, people are like, well, I can get it for 3 months or 6 months at the clinic, I'm already getting it. But they're still paying $30 maybe at Walgreens versus $2 for the same amount of time. So that's the part we have to drive home.
I mean, it's significant. Like,
Yeah.
I mean, no-brainer,
Yeah.
shout from the rooftops type,
If you can get them to the point of doing the math,
right?
you're golden, but we've also talked about how Walgreens is the preferred provider right now, and we've spent a lot of marketing steering people to Walgreens.
Yeah.
And people have had a lifetime of going to the pharmacy, so I think we're fighting this human nature to want to continue that, but it's a great product. I mean, it's a great service that I think will get there. The numbers are just too sound not to continue to try to. And I would say it's probably 20% of every one of our meetings is, okay, how do we steer that?
Get it.
And it's a tough slate, but I do think having the HRAs at the clinics,
Yes.
they at least know where it's at. It's a beautiful facility. I mean, they're both beautiful facilities, right? And we're really hoping that's kind of a kickstart to some growth as well.
I look forward to seeing the results in a year from now on just this change and what that does.
Yeah.
Mr. Wad?
Yeah, I just wanted to dive in maybe a little bit into what the potential additional savings would be if we were to if we were able to drive the amount of volume to those kiosks. And I'm assuming that a big piece of that is these management,
Maintenance.
Yeah.
maintenance
Medications.
medications, right? Do we know how much more? Do we have any estimates as to how much additional savings the district could enjoy if it was utilized at the level that we targeted?
Last year, when we kind of looked through the prescription data and trying to identify the formulary for the machine, if the machine was utilized at its fullest potential, there was, and please don't quote me on the numbers, but just kind of a round number from memory, was about a 20% savings on the prescription side of the insurance cost to the district.
Which is significant because pharmacy is the second largest besides maybe inpatient
You wanna-
care. Yeah.
Well, and I believe I saw in the presentation we have coming that that's increasing, the cost of pharmacy is increasing significantly right now, right? At least for us.
The specialty,
Yeah.
in particular, we're going to spend a few slides just on that topic in
Yeah.
a few minutes. Can you just a point of reference, how many scripts do you have, or how many drugs are offered through the kiosk, just to give you scale as to how
There's,
wide of offering this is?
there's roughly 110 prescription prescribed medications along with 10 over-the-counters, and I have room to add. I have room for about another 25 medications inside. Now, the medications that we're targeting here are essentially the maintenance medications. They're usually the medications that are provided generically as opposed to the brand name products. Brand name products, when you start looking at the overall distribution and the usage, there might not be enough usage in that one individual item to warrant the ROI. But in these maintenance type medications, when we can start looking at what product is going to provide the best overall reduction of lipids, if we're talking about statins, we're able to manage that formulary a little bit better. We're working with our group of nurse practitioners and providers that are able to then manage that patient to that formulary, and we're able to get a very high utilization from that.
Yeah, I'm looking forward to seeing how we solve this because this sounds like a great opportunity for us and for our staff.
And we do share that prescription, the list of drugs that are available, it is on our staff website, so all staff can see if the drugs they're taking are available there to even make that appointment.
Dr. Piasek?
Just to clarify, that I understood correctly, what is the longest fill somebody can get from the kiosk? Is it 90 days?
1 year.
1 year.
1
You get a
year
year, okay.
for $2.
And if they have refills, they can just come back for a refill?
Correct.
Do they have to schedule that?
Yeah, they
Yeah.
schedule an appointment to be seen. Yeah.
To be seen,
Yep, to refill. So
refill.
we want to check their health. So
I'm saying like if they have, say they have a prescription that has 2 refills on it, can they just come back and get that refilled via the kiosk?
We
So
Go ahead.
Or
in
that would
most
go to-
cases, what we would do in a situation like that, whoever was talking about, traditional pharmacy experience, I think this is where this kind of diverts a little bit. Most maintenance medications, if you've seen your provider, they're going to give you maybe a 90-day supply with 3 refills to cover you for a year's worth of time, and then have a visit within a year. And that 3-month plus 3 refills is usually articulated by the insurance company saying, we're only going to provide a 3-month supply at a time. In this process, as opposed to having people come back for refills unless there's a warranted, I need to do a blood pressure check or a statin check or a lab visit, we're just giving them the year's worth.
That's even better. I didn't mean to cut you off. Just to clarify my question, yeah, okay.
Mr. Borowski?
Just a question or two. I guess it'd be slide 10, where you were talking about the yearly clinic visit totals and utilization. For 22, 23, it was at 58%, 24, 62%. Seems pretty consistent. maybe I'm not thinking about this correctly, but it sounded like you said it was getting close to needing to expand the hours. Wouldn't it need to be closer to like 100% utilization to expand?
No, a provider can't work at 100%. So you have to remember that they have to see you and they have to chart and they have to do some things. So usually physicians work and providers, APPs, work at 50 to 70%. That is capacity.
Okay, so that's the wheelhouse, if you will.
Yeah,
So
and
that-
remember, we're not working like that. We work till midnight every day for you. So you might have a patient that gets seen at 8 o'clock at night or at 11 o'clock at night. It's not the traditional, you come into your physician's office and he or she is working 8 to 6 and they're doing 15-minute slots. We've got services all over. So what we do is we take the type of patients you have, whether it's 15, 30, 60, 90-minute appointment, whatever it is, and calculate that based on the hours.
So then if we did have to increase the hours, how does that impact our cost?
It would be financial, obviously, and that's our hourly rate that we've agreed to. Yeah. So
I
we
think-
just wanted to let everybody know we're kind of getting close.
Yeah.
I believe the contract specifies 40 hours now, so actually that document would come back to you as an addendum, or
Right.
maybe we take a look at the whole thing at this point, it's been a few years or whatever, but it would come back to the board because it was, a specific number, if I recall it correctly.
Yeah.
The tweaking of the hours of the 40 wasn't in the
No, none of it.
contract, it
Or
was
the
just,
extension of the virtual or e-visits.
Right.
Yeah, that was all
Those are
just
all
value added.
added.
Yep.
Yeah.
And then do you usually recommend certain increments of increasing that?
Yeah, we usually go by 20, but we could go by 10, because you already have a significant amount of time you're spending, just to kind of test the waters. Yeah.
Okay.
Just don't want to get to a point where someone wants to make an appointment, especially in the standard clinic, and we can't see them, or a walk-in comes in. We saw in the characterization of a patient experience that they were in urgent care, which is alongside of us. And we had, the folks had the wherewithal at the front desk to say, your school district of Waukesha, you should be seen over there for free. You don't need to be seen here for urgent care, where they would have paid out of pocket. So we want to make sure that we're always available like that they can walk in or have an appointment same day.
Yeah, that's great.
Yeah.
so just in closing, usually the biggest question I get, our most frequent one is, are you doing better than the previous clinic? And I think if you just look at numbers of visits, I think, even though I think we're more conservative in counting a visit than the old one was. But also, we talk about this as the employee clinic, but it's really, in my mind, become a suite of healthcare options with virtual and e-visits, and now this kiosk. It's really getting hard to compare it to what we once had. So, but like I said, everything's gone well. We work great together as a team. I'm really hoping that the HRA being in the clinic will help smooth out scheduling for Kristen as we push maybe more to the clinic, but just to get that foot traffic in there. And then we meet monthly, but Kristen and Laura, I know, probably talk at a much more frequent basis. And Kristen and they both do just a fantastic job. So we couldn't be more pleased as a partner so far, and we continue to talk about new ways to. I keep thinking there's gonna be this like break moment where a flow is coming, and maybe this HRA is coming. But even though our numbers are better than what we used to have at a more reduced price, so.
Well, thank you.
Thank you.
Thank you.
I look forward to next year's.
Yes, we do too.
And thank you.
Thank you.
Darren, we're continuing on with insurance, correct?
Yeah, Jeff will come up and talk about our overall health plan and RX in more detail.
Good evening, everyone. Great to be with you again. On the heels of that great pro healthcare report, and I did some calculations in the back to answer those questions on RX. So when I'll put it in context for you. That's okay, all right? Yeah. So just wanted to give you an update as to where we were. As you well know, your plan renews or open enrollment takes place in the summer into September. So we have a September plan. So now is an appropriate time to take a look at the financials. There are a lot of numbers here, a couple concepts, so feel free to interrupt me. Might be easier during the conversation to address any questions. That way it might just be easier for you. So if we just talk about healthcare, it's complex, it's dynamic, it never stays the same. But there are really two major stakeholders in yours and in any employer situation. You've got the employer things to do, if you will, and the employee things to do. It really can be broken down to those two buckets. And underneath each of those two buckets are really what we've identified as 3 strategies for employers to address and 3 strategies for employees to address. And I'm not going to bore you with all this, but everything an employer needs to do to attack healthcare costs fall into one of those 3 strategies on the left-hand side. And everything that we need to help employees do, that Kristen and Darren do on a day-to-day basis, fall into the right-hand side. So when we get together as a team, we're constantly advancing the ball, if you will, and working under the guise of a playbook that drives these strategies. And I would just compliment the district who has for years taken this very seriously. You are not a district or an employer who sits on their hands and just takes the increases and lets it go. You actually work a plan to enhance the value of the benefits for your employees, to create innovative programs like you just heard about Access, which was at the top of our list a few years ago, and yet address whatever cost drivers we're unveiling in the data. And you do it, and you don't wait around 2 years to do it. So, just good for you that you actually are an active participant in managing this big cost area for your district. So, along the same lines, some of you may be in a business where there's a supply chain. Well, there's a supply chain in healthcare. It's very complicated, but at its very core, if you take a look at the box, there's really 4 components to the supply chain. And what we continue to do is try to take the vendors and partners that the district works with on the left-hand side and try to align the motives so that we can squeeze as much waste out of the supply chain as possibly can. The physician services, obviously clinics, just a huge part of that, as well as the outpatient care. Inpatient, we have programs with United Health and prescription drugs we'll speak to in a little bit. But we're working all the dials, turning all the dials so that we can address what goes into the equation, because those organizations who don't pay attention to the supply chain, it's sort of garbage in, garbage out with their healthcare. They don't do anything to manage it. Guess what? Their costs are going to escalate at a more rapid pace. So that's just all sort of macro information. I'll touch on some very detailed information here for the district. Then, as far as your numbers. So I'm just going to rip through these pretty quickly. You spend about $22 million a year on health benefits, including your prescription drugs. You are self-insured. You retain the first $325,000 of all claims for each participant under the program. After that, stop loss kicks in, and every year we take a look at who's going to provide that reinsurance. You've got a little over 1,000 employees and over 3,000 total employees and family members participating in the program. So that's a lot of people you're taking care of. We have 2 major partners. United Healthcare pays the claims on the medical. Navitus interfaces as a PBM, pharmacy benefit manager. They coordinate, pay all the claims on both sides. Couple things you've done with your supply chain: maximize the provider contracts. We're constantly working with United Healthcare. On a regular basis, we analyze whether the United network infrastructure provider deals are the best for your group versus Anthem, Aetna, Cigna, Network Health, all the rest of that. Stop loss levels. I mentioned a $325,000 retention, or we call it a specific deductible. Every year we've evaluated, is that the optimal? Do we take it up? Do we take it down? It's all based on pricing, and we've moved that retention up over the last number of years. We don't want to overpay the insurance carrier for the protection, but we don't want to overexpose the district to too much. So that's just a fine-tuning exercise that goes on. You heard a lot about the clinic, how we implemented it, how we consistently just tweak and try to re-engineer. We've got the kiosks, we've got, the Sunset location, we got HRAs going to the location. We're encouraging employees to use the kiosk, which is a huge thrust of our efforts. We're talking about hours, so there's constant tweaks going on to that. I'll talk in a little bit more detail about what we saw historically about your historic prescription drug trends and what we've done about it, but we really deployed the best solution that was available at the time to attack those costs, and you'll see what occurred there. And then, we get together on a monthly basis and then do a deep dive on a quarterly basis and say what's the next thing that we need to do because of the dynamic nature of healthcare. So, any questions on that? Okay. Let's talk about your costs, what's happened. A lot of numbers on this, but I'm going to just draw your attention to a couple of them. Happy to address any of them. Over the last 3 years, you've experienced a total cost increase of 7%. That's being measured on a per employee per year basis. So we can't just look at your trend, because if your head count goes up or down, right, we got more people covered or less people covered. That's not fair. You can't say. You have to take it based on the number of employees. So your total cost has increased 7% over the last 3 years. In an environment where annual healthcare cost increases on the medical side, somewhere between 7 and 11% per the experts, and the drugs 10 to 15. So we've outperformed because of the good work your team has done in continuing to keep their eye on the data, do the things that they're doing, encourage good employee utilization, those things. This past year that we just finished was higher than expected. So if you look at healthcare financing, it's also cyclical. Over a 5-year period of time, a group like yours will probably have 3 to 4 very good years, but you're going to have a clunker. We had somewhat of a clunker this past year. It wasn't devastating, but it certainly wasn't what I'll draw your attention to in the yellow highlights down on the bottom of this. When we take a look at the total cost per employee per year, in 2021, you see $17,027. 21-22, you see $16,545. That's a 2.8% reduction. So we're measuring against the prior year, saying our costs actually went down on a per employee per year basis. Just say that the total cost divided by the number of employees, our costs went down by almost 3% in that year. And then our costs only went up by 2% the following year. And then in 2023, our actual cost per employee per year went up 8.2%. The natural question is, why did that happen? And I draw your attention to the fourth line from the top there. We had medical cost increase of 10% and prescription cost increase of 37%. We had some spikes in there that had not previously occurred, and some spikes that have already, that we anticipate not to occur on a go-forward basis. So they were one-time
So when
events.
we're talking about the spikes, are we talking about the actual cost of the care, or the care was an anomaly? So there's two different pieces, right? There's a cause for the care, and then there's the actual cost of the care. Was the cause of the care the issue, or follow?
I would say both.
Okay.
So we had unusual situations that cost a lot of money that won't repeat in the coming year. That address your question?
Yep.
Yeah,
Thank you.
okay. So it wasn't just like, we had 10 more back surgeries than we normally had. That wasn't, it was just some unusual things that we had not, our history had not demonstrated were predictable. Okay? And lastly, when we take a look at that cost per employee per year, you can see the number that I drew your attention to, the 17,027, And then the next number, 16,545. If you take a look at the last number on that page, you see the national average cost for government. So what that is, that's a benchmark that's published that says most municipal entities, school districts and municipalities are trending at this cost per employee per year, and you see that our numbers pretty much track with the averages. They had been previously a little bit better. Okay. Again, a lot of numbers, but the next frame just speaks to the fact that in these up and down years, and I'm going to get to this in a second, we have, because your team has worked very hard to attack the cost drivers, we have created surplus reserves. The reserves of a health plan have to be used for the benefit of the health plan participants. You can't necessarily just take reserves and say, well, I've got, Darren can't say, I got 5 million sitting in reserves, I'm gonna go and buy football uniforms with them. That's generally not what happens. It's for the benefit, their statutory requirements for the benefit of the beneficiaries. So what we've done in the last couple of years is healthcare continues to increase, and when we set budgets, think about it. If you have a $20 million spend and healthcare costs are predicted to go up 10%, you're going to face a $2 million increase just about every year. Well, what we've done is instead of passing that along to all your beneficiaries, all your participants, or increasing your plans so that they pay more in deductibles and coinsurance to cover that, we've used the excess reserves that have built up over time. And so that's what we're just pointing out here, that we're constantly, as a part of the financing, taking a look at what can be used in reserves, so we still have adequate reserves, but beginning to draw down the reserves that were built up in good years. And some years, when we've allocated reserves, we've used them all, and other years, we haven't used them. So it's been sort of a wash in terms of, remember, we're trying to predict out 12 months into the future of what your health care looks like, and sometimes we can't do that. It's not a perfect science. So, all that to say, you have excess reserves because you've managed it well. We've used some of what we put aside for a rainy day to offset future cost increases. All right? The next frame, I'm not going to spend a lot of time on this, other than to point out two numbers for you. In the middle of the page where it says total planned costs, you have a 21.496 million number and a 21.990 number. The far right hand is the predicted or projected cost for the plan year we're in right now. And if we were to take the first 2 months that we're in, September and October, that's all we have in posted for this year, and we're to annualize those and say, are we on track for what you could see that we're at 2.5 versus 2.9 or 22 million. So we're pretty much right on budget. You can't really predict with 2 months, but all that to say, there's nothing wild that's happening in the first 2 years. We're on track. Okay? Okay, so this is a pretty fancy frame, but I would just say concentrate on the trend line. You see what's happening there. What's happening there is an increase to that trend line. So when we take, and best practice in healthcare is to take the last 36 months and try to create stability in that trend line. That's what an actuary does. And say, this is the predicted, this is where we think it's going. You see in the numbers below, the 24-25 average has already, which is the first couple months of our plan year, has already dipped down. So my point earlier about how we had some spikes in the prior year, but we're beginning to see a reduction. And we also know intuitively that some of those claims aren't going to repeat. We're going to see a leveling off of that medical trend going into 24, 25, even more. Okay? The next frame is an example of what happened and some of the work that your team has done relative to that. So this is specifically around prescription drugs. You don't have to be a statistician to take a look at the trend line on the left and go like, holy smokes, what in the world's going on? Well, what in the world was going on is the escalating cost of prescription drugs, particularly what we call specialty drugs. These are drugs that cost, anywhere from, let's call it $500 a month or more, but there are many drugs that are costing $10,000, $50,000, $80,000 per year per patient, $120,000, and there's just an enormous amount of pressure. So that was your trend line back in 2020. The last date on the last thing was in 2020. The one on the right is, you see, flattened out and then reduced. That was when we put a program into place with our current pharmacy benefit manager to begin to attack those costs. And the manner in which they attack those costs is to work with your employees to determine whether or not they would be eligible for what we call manufacturer's assistance. Manufacturer's assistance is the last thing you hear on every ad that you see or hear on the radio or TV. Ask your pharmacist if you qualify for a $5 copay. And by the way, every drug you see on TV probably costs in excess of $80,000 a year, some of them $200,000, $300,000 a year. And the drug manufacturers create programs for folks that will literally give the drugs away for free or close to free. And so we've subscribed to those programs. We've used them as best as we can. And what you see is the trail off of your trend line is a result of deploying that resource. And you and hundreds and thousands of other employers across the country are doing this, because without it, the cost would be unsustainable. Okay, so this is an example of setting a strategy, looking at the data, setting a strategy, doing something about it. Okay? But the next frame shows you the trend line that's now continuing, and it's continuing up. So not only did we have a 37% increase, spike in the drug cost, some of which won't be repeating, there continues to be pressure. And I'm going to talk about it as a to-do item, but there continues to be an upward trend again, and I'll explain that in a minute, and I'll explain what we're going to do about it. But all that to say is we can't rest comfortably on our prescription drug trend because it's continuing to trend back up, if you will. All right? So let's just talk about the last few years. We had two big wins. The biggest wins were the clinic, and you saw the numbers, 500,000 to almost 600,000. And by the way, those are actual numbers based on what you were actually spending previously in the prior clinic. So literally, $500,000 got dropped to the bottom line annually by going with ProHealth. We increased access. We created a virtual healthcare delivery system with virtual e-visits, 2 locations, very convenient, and dispensing on the RX side, and saved $500,000. And patient satisfaction scores of almost five points out of a 5-point scale. So that to us is a big, big win. So continue to work with that. The other thing is when we instituted the prescription drug program, what I'll call the specialty program, the specialty diversion program, the specialty drug, the manufacturers, we saved $1 million a year. And we're still saving, but that savings is deteriorating. So I'm going to get to what we're going to do about that. The other thing that's really incredible, I think, that you should be very proud of, 21, 22, and 23, no employee premium changes. You did not pass along increases in employee cost to your people. That's outstanding. And it's really because we're squeezing the waste out of the system, and then you take that and you reinvest that back against the increased cost instead of putting it on the backs of your people. Okay? In 2024, you see, we asked for a 4% employee premium increase. We did. And We also increased the deductible that they pay and out-of-pockets slightly. In 21, 22, and 23, we didn't make any plan design changes except for what the IRS required on the high deductible health plans. So that's something to be very proud of. Your ability to maintain really, really competitive benefits in the face of increasing costs in the marketplace when your costs are increasing at a rate that's 1/3 or maybe even 25% of what others are seeing because you're working at it. So that's amazing. That's what should be happening. The clinic strategy, I'm not going to bore you with everything that Vicki and her team talked about, but you see the focus on increased participation in the RX dispensing. So I put this together independently of everybody else. It's what we're focused on. But really, the triple win is the district, the employee, and the efficiency overall. And when we talk about the dollars involved, wow, I had that all calculated out. Just a second once. There we go. So just to give you an idea, you asked the question, Mr. Watt, about what potential additional cost savings there could be. So you heard Mark say 20%. 20% of what number? Well, if we could flip to the next frame, this will make more sense. So specialty drugs, I'm just going to go with this for a second. You currently spend $5.2 million on drugs. 63% of that is specialty drugs. If you back out the specialty drugs, we wind up with about 1.9, 1.8 million in drugs. Now, all those aren't maintenance medications. They can't all be dispensed. He's only got 125 or whatever on the list, 110 on the list, okay? So if we said, and this is rough carpentry, right? But if we said there's about $1 million worth of drugs that if we optimized, we could save 20% on, it's 200 grand, right? And your employees are paying $2 a year for a potential full year's supply. That's why Kristen and Darren are making this a priority. And the other thing is, as Kristen indicated, when we went through our Navitus year-end review, we found that people have migrated under that ecosystem to the 90-day fill. We may have some tough conversations about saying, do we want to still allow that? Or do we scale that ecosystem back to 30 and incent the clinic so that they can get it for $2 for 90 or 180 or 360 days? And so that's the kind of thing we're working on, again, the next thing. So that was the clinic, and that's our focus. And then, so I do want to just stay on the prescription drug page here because I was just answering the question. But here's the work that we anticipate to kick off very shortly around prescription drugs. And here are the data. You spent $5.2 million. It was at $3.9 million the year before. So $1.3 million increase in prescription drugs for 1,200 people. That's huge, okay? We know some of it's not going to repeat. 63% of that cost were those drugs costing over $1,000 a month, and that subset increased at 26%, okay? So the most 63% increasing at 26%, that's not a good future view, right? What we believe is that the program through our pharmacy benefit manager, Navitus, has lost a little steam compared to the marketplace. Doesn't mean that Navitus was a terrible choice. We've had them for a long time. They deliver great service. But you see the 2025 PBM review anticipated. We anticipate reviewing that relationship and other, what I'm going to call specialty prescription drug diversion programs to determine, can we stave off those increases better in a different system, a different chassis than Navitus? Because Navitus does a good job, but they might not do the best job. So we're just about to start looking at some of the data. Then we're going to make a decision when we're going to do this, but obviously you'd be involved in that decision. But candidly, I'm pretty excited because if there could be, beyond the 200,000 there could be another 400,000 potentially on the table that we could deliver in savings. If we find that Navitus, based on our intuition, has lost steam and we could transfer a relationship to someone who is, sort of leading the pack on that. Without impact to your people, other than maybe an ID card change on the drugs. Still get their drugs for free, the whole business. So I think, excited about historically where we've been, disappointed about where we ended last year, but those things aren't always in our control. Sort of in the normal cycle of healthcare financing, we got a lot of work to do with the clinic to continue to push that forward, and a lot of work to do with the PBM, and we're excited and probably be back to you sometime over the next few months with some ideas and recommendations. So.
No, sounds great. I like the savings piece. It gets a little bit lost with the cost increase versus true savings year over year, but
Yeah.
I think we can pull that back. Any other, Dr. Piasek?
Yeah, I don't want to get too much into the science and healthcare side of it, but it seems that there's a lot more biologics being used, and those are the really expensive ones, right? But they work, and they can target specific things that couldn't do before. So in the interest of wanting to provide the best possible care, is there a cost strategy around biologics other than the 1-800 number with the manufacturer that is to sign up for the discount program?
Yeah, that's a great question. So the biologics are driving costs, and recently, over the last year and a half, biosimilars have come out that probably can reduce the cost by 75 to 90% of those drugs with similar efficacy. Not for everybody, but if 90% of the folks can take it, that's a huge win. So part of this PBM review process is reviewing sort of the rules. So I talked about the rule about, how we can actually dispense a $2 prescription to an employee for a year, and we opened up the floodgates under Navitus, and they seem to embrace it. Under that, do we need to change the rule, the administrative rule, about what gets the first look, or what steps employees need to go through? And I don't mean restricting care, because that's not what we're about. But if the first look is the $10,000 medication instead of the $150,000 medication, as a steward and fiduciary of the program, and as a person who people look to for recommendations, that's generally our recommendation, as opposed to the healthcare system, because they're making a lot of money on the $150,000 drug, much more than the $10,000 drug. It's way easier for the doctor. He's getting called on by the drug rep. Sorry if, offend anybody, but, all that kind of stuff. It goes back to that frame where I said we have to align the motives. And part of that's education. So that's part of that conversation. Is what are the rules? What are the administrative rules of our plan? And we can create lots of hoops or no hoops. And I would say that historically what our philosophy has been, correct me if I'm wrong, is that we want to create incentives for people to get the drugs that work the best at the lowest cost. Okay? The drugs that work the best at the lowest cost. Not start out with the highest cost and cross our fingers just because the doctor said that was it. So that's a balancing act that we all have to take, and we have to communicate to employees, because the reality is if we sustain 20% increases, their costs are going to go up too. So to the extent that we can be good stewards and continue to manage it, we're going to be able to pass along no increase or 4% increases. Does that help?
Thank you.
Also, we did have 8 employees on Humira, and when the biosimilars came out, all 8 of those members received communication from Navitus, and all 8 of them actually did switch to the biosimilar.
There you go.
And nobody is on that high-cost drug anymore.
That's a great example.
Yeah, it's a
That was-
perfect
I was trying to
example.
find
Thank
that
you,
data. I was
thank
like, we
you.
just had the year-end
Thank you.
review, so
Yeah.
I thought that was a really big
That's a win.
win.
Yeah, you can't really.
Because Meyer is 85,000 a year
Yeah.
per person. And we had
And
8.
Stellara's coming out with one, hopefully in '25.
And Stellar's almost $300,000 a year per person, per year.
Can't put them in the kiosk.
No, can't put that in the kiosk, no, unfortunately. No.
Okay, thank you.
Great. Well, thank you. Today is the day for insurance. I went through the insurance analysis with my job today, too, and got it all out.
Okay,
Feel well-versed. This was good. Thank you. We look forward to seeing what's coming.
yeah, thank you.
All right, thanks, Jeff.
Thanks, everyone. Great to be with you. Have a great night.
I'm going home.
All right, so our next discussion item is the monthly budget report.
Yes, so with the budget this year, there's a couple things. The 24-25 budget that you guys have approved is in Skyward now and active. Everyone can see it, both at the sites as well as, throughout the district. Our salaries and benefits are on target as expected at this time of the year. And just wanted to bring your attention again to the capital and non-capital objects in the budget. You notice a large difference between last year to this year, and again, just bringing to mind that that has a lot to do with the ESSER funding that we no longer have. So if there's any questions, I'd be happy to do my best to answer or get back to you.
Not seeing any.
I appreciate this look at the budget. It's very helpful.
Excellent, thank you.
All right, not seeing anything else. Our other business, is there any recommendations for future committee meetings? Seeing none, we do have a need to adjourn to executive session pursuant to Wisconsin statutes 19.85, parent 1, parent E, for deliberating or negotiating the purchasing of public properties, the investing of public funds, or conducting other specified public business whenever competitive or bargaining reasons require a closed session. Looking for a motion.
So moved.
I'll second it.
Okay, it's been moved and seconded. Mr. Clark, you want to roll us?
Mr. Zenobia?
Aye.
Mrs. Kozlowski?
Aye.
Mr. Borowski?
Aye.
Dr. Piasek?
Aye.
And Mr. Watt?
Aye.
Motion passes
Right.
5-0.
We are closed.